Okay. Good afternoon, everybody. It's a pleasure to be with you here today and be moderating this panel. I'm Miles Berger. I'm an anesthesiologist and researcher at Duke University. The title of the panel is "So Doc, I Hear Anesthesia is Bad for My Brain: Translating Research into Shared Decision-Making and Better Care for Older Patients Concerned About Perioperative Neurocognitive Disorders." So we have not received any commercial support for this program today. It has been planned in accordance with everything you can see there. There is CME that's can be obtained with this, and physicians should only claim credit commensurate with the extent of their participation here. A quick plug for the IARS AUA SOCA meetings in 2023 in April in Denver, Colorado. Be great to see you all there. Outstanding meetings for anesthesiology and critical care related science. The abstract submission is open now, and the submission deadline is December 2nd. Abstracts are welcome, as it says there, on all aspects of anesthesia research, academic anesthesia, and critical care anesthesia. And if you missed the 2022 IRS meeting, on-demand access is available for members only, and you can visit that link there, meetings.iars.org/program-education/on-demand. And the presenters here that we have today will be available for questions and comments after this session, continuing the discussion in the IRS member community there on docmatter.com. So docmatter.com/IARS. And if you need help, you can email them at support@docmatter.com. And we'll have a Q&A. Please use the Q&A button on the Zoom taskbar to submit questions, and we'll try to address those in a Q&A at the end. And you can see some options here for claiming credit for this, etc., listed on the right. And so it's a pleasure to be here with you again and be doing this panel. We have three outstanding panelists who will be talking to you today, Drs. Odmara, Barreto, Chang, Elizabeth Whitlock, and Stacie Deiner, who are going to give three talks today here on this subject. And I'm going to stop sharing now, and I'm going to pull up the intro here. So Dr. Barreto Chang obtained her MD PhD from Stanford University and then completed an anesthesiology residency and fellowship at the University of California at San Francisco. She is a clinical anesthesiologist and neuroscientist whose research and clinical interests focus on understanding both the molecular and the behavioral basis of cognitive impairment after surgery. By focusing on the perioperative period, she seeks to improve both the information that patients receive during their pre-op evaluation in terms of brain health assessment and to develop potential neuroprotection approaches during the period of surgery and postoperative recovery. So with no further ado, I give you Dr. Barreto Chang.
Thanks, Miles, for your kind introduction. As you mentioned, the title of my presentation is Grandpa is Just Not the Same: Risk Factors and Impact of Short-Term Postoperative Neurocognitive Disorder. These are my conflicts of interest. I'm an investigator for the clinical trial Oliver, and here are my sources of current and past funding. So today I will be talking about perioperative neurocognitive disorder nomenclature, the risk factors for postoperative delirium, and focus on baseline cognitive function. I will discuss the perioperative brain health evaluation and give some suggestions on how to discuss perioperative cognitive evaluation with patients. So cognitive impairment after anesthesia and surgery is a concept that has been reported for more than half a century. In 1955, Bedford published an article in The Lancet, which explains some of the common cognitive complaints that older adults had after surgery. Here you can see a summary of some of the most common complaints. For example, he's never been able to write a decent letter since. He's become so forgetful since. She can be trusted to go out shopping since, and the list goes on. Just to put this in perspective, this is a news article from 2022, and the title is "The Hidden Long-Term Risks of Surgery. It gives people's brains a hard time." In this article, the woman described how her father, a former physics professor, has shown signs of significant cognitive decline after the initial operation. Once a keen chess player, he was now unable to play the game and struggled to even do basic crosswords. Most of us are familiar with the story, and especially with the common concern, grandpa is not the same after the surgery. So in the past, different names were given to cognitive impairment after surgery. The nomenclature was very confusing. And in 2018, a group of experts put together some recommendations for the nomenclature of cognitive changes associated with anesthesia and surgery. Using this nomenclature, perioperative neurocognitive disorder is defined as the cognitive impairment or change identified in the preoperative or postoperative period before the surgery, up to 12 months. As you can see in this diagram, there are different terms used to describe the cognitive impairment at specific time points during this continuum. Preoperatively, patients are cognitively normal or have a neurocognitive disorder, NCD. After the surgery, the cognitive impairment is sometimes classified as emergent excitation or post-anesthesia care unit PACU delirium while recovering from the anesthesia. Postoperative delirium occurs up to 1 week post-procedure or until discharge from the hospital, whichever occurs first. The nomenclature then changes to delayed neurocognitive disorder for the period up to 30 days after the surgery. And after the period and up to 12 months afterward, the cognitive impairment is considered a postoperative NCD. You may ask yourself why it's important to diagnose cognitive impairment prior to surgery. Cognitive impairment is a risk factor for PND, and it's estimated that more than 4 million surgeries are performed in the United States in patients 65 years and older. PND is the most common complication in surgical patients, with an estimated 1.6 Americans suffering from PND each year. Postoperative delirium is reported up to 50% and postoperative NCD 10 to 15%. And patients are often unaware of having baseline cognitive impairment, so early identification can lead to improved medical care and referral to supportive care. As I mentioned, postoperative delirium is the most common complication in older adults after surgery. It is characterized by fluctuating changes in attention, mental status, or level of consciousness. It is associated with increased hospital costs, duration of hospital stay, and healthcare complications, in addition to an increased morbidity and mortality. Up to 40% of delirium has been reported to be preventable. And also, decreased POD could lead to decreased long-term cognitive decline, as it has been suggested that delirium may be an independent risk factor for long-term cognitive decline after surgery. There's a lot of information in this slide. This slide summarizes a lot of the work that many investigators have done over decades. All of these risk factors, age and cognitive impairment, are the most commonly reported as strong predictors of postoperative delirium. In addition, we can see lower education level, sensory impairment, decreased functional status, comorbid medical illness, malnutrition, and depression, among others. So you may ask yourself, since we have different risk factors, what about predictive models? In 2022, Wang and colleagues published a head-to-head comparison of 14 currently available predictor models. And they concluded that only 2 of these models have fair discrimination and acceptable calibration. Both models use age and baseline cognitive impairment as part of their variables. So there's still more work to be done in predictor models that can be used across surgical specialties and patient populations. So if baseline assessment of cognition is important, how to get one done? The problem is that there are some challenges here, as this is not part of the standard preoperative anesthesia evaluation. In 2020, Dr. Deiner published a paper reporting that only 4 to 12% of anesthesiologists do a preoperative screening for cognitive impairment. Furthermore, the American Society of Anesthesiologists recommends early identification of patients at risk for postoperative delirium to develop plans of care and optimal resource allocations. There are some common barriers here, such as a lack of time to do these assessments and the need for fast interpretation of the results. So what assessments are used in my hospital? Is there a multidisciplinary team that can help with the interpretation and counseling? Depending on your hospital setting, you may have access to some of these risk cognitive assessments. Some of them are paper-based and some are computer-based, as the one that I have been using at my institution, which is in the corner here. An important thing about these brief assessments is that they need to be short and they need to be easy to be done by the patients and the people administering the brief cognitive testing. In this example, the one that we use at our institution, this is a computerized testing that has a standardized administration, has a precise response, automatic scoring, and the ability to export the results to EMR integration. Also, this assessment can evaluate the function in 4 different domains, such as executive function, memory, language, and line orientation. So once the patient undergoes cognitive screening, what is next? So we propose a care pathway where older adults that are identified as being impaired at baseline by cognitive screening are flagged in the electronic medical record as a high risk for PMD. This information can alert the care team and the family, and for them to make appropriate interventions during the hospital stay. The results are to be disclosed with the patient and the family, and in some cases, when appropriate, rehabilitation can be considered, and the patients can be placed in a delirium care pathway. So one of the hardest parts is disclosing the results. When a patient is found to have baseline cognitive impairment during the preoperative evaluation, they may want to know, is this dementia? Is this reversible? Will it get worse? How fast? How these results affect my surgery? It's important to offer care options for follow-up, such as involvement of geriatricians, neurologists, and neuropsychologists. We need to remember that these are brief preoperative testings. These are screening tests. So further evaluation by a specialist is needed for diagnosis. We also want to emphasize creating multidisciplinary teams to care for these patients. And importantly, to educate the patients together with the families and caregivers to inform of common complications of POD and to engage them in the post-operative care planning. So what does it mean if I develop post-operative delirium? So for the patients, this means that they may have an increased length of stay. The cost of care may be higher. This POD is also associated with increased morbidity and mortality, and they also may require long-term family support. In addition, it has been reported that those that develop delirium during the hospitalization use twice as much healthcare And the estimated national burden of delirium on the healthcare system ranges from 38 billion to 152 billion per year. We have some challenges and barriers ahead. One of these is disclosure of preoperative brain assessment is still an area of development, can often be difficult to communicate the results because of the fear and stigma about mental health. What happens when it's not diagnosed or complications of POD are not discussed? Most of the patients and the families are unaware, and this can be more difficult for them to understand brain changes. So it's important to discuss expectations, resources, and how to cope with POD, as this can take a toll on both the patients and the families. For example, things to discuss would be like, is the patient will need additional skilled nursing help at home? Is there family support after the surgery is done? And to make sure that the patients and families are connected with the adequate resources and to follow up with in the post-operative period. Finally, the emphasis on a multidisciplinary team. This includes geriatricians, primary care doctors, neurologists, neuropsychologists, surgeons, and anesthesiologists. So in summary, preoperative brain evaluation has multiple advantages. It helps identify those vulnerable patients. Also, it helps inform the patients and the families of the risks. Minimizes risk, can allow to minimize high-risk medications and incorporation of post-operative protocols. In addition, this is recommended by the American Society of Anesthesiologists and the Brain Health Initiative. I would like to thank the International Anesthesia Research Society for the opportunity of allowing me to present in this webinar. I also would like to thank my sponsors and mentors and my sources of funding. Thank you.
Great, thank you, Dr. Barreto Chang. That was a great talk. And our next speaker up, we'll take questions at the end for all three talks. Our next speaker looks like Dr. Elizabeth Whitlock. She's an anesthesiologist and epidemiologic researcher with expertise in perioperative neurologic complications, including delirium, intraoperative awareness, PTSD, and epidemiological modeling of long-term pre- and postoperative cognitive change. She's the recent awardee of an R01, congratulations, which seeks to model expected long-term postoperative cognitive outcomes in a broad population of older adults. So without further ado, Dr. Whitlock, please take it away.
Thanks so much, Miles. Excited to speak with you guys about my area of focus, which is on long-term cognitive change. I don't have any conflicts of interest to disclose, and no off-label uses will be discussed, but I appreciate the name drop on the R01, which I'm really excited about, started about a month ago. I'm going to go even further back in time than Odmara did and highlight this description of postoperative cognitive change published in 1887, Insanity Following the Use of Anesthetics in Operations, which is particularly evocative. And this was obviously a description of permanent cognitive change of maybe unclear relevance to current anesthesia practice, but maybe more recently, this is the paper that I think kind of opened up this area. This was a study of people who underwent CABG surgery, published in the New England Journal in 2001, and they tested CABG recipients before they had their surgery, and then serially until about 5 years post-op. And at 5 years, their cognition was poor. Everybody panicked, and the way that this was covered in the popular media included stuff like a quote from this cardiologist that said, for a high-functioning 75-year-old, I look at these cognitive outcomes long-term after surgery, and I think they're so unacceptable that I might not even offer definitive therapy to a high-functioning 75-year-old. I might use some sort of suboptimal therapies because I'm so concerned about the likelihood that this cognitive outcome for this patient would be unacceptable. This is scary stuff. Odmara and I are quoting the same articles here. So this is an anecdote described in The Guardian of 2 years plus of cognitive change experienced by somebody after a heart surgery. And similarly, this article from the Washington Post, now a couple of years old, cites an anecdote about Dan Cole's father. And Dan Cole is a recent past president of the American Society of Anesthesiologists. His dad sustained at least 2 years of durable cognitive decline after his CABG surgery. And these are the anecdotes that are accessible to people who are pursuing potentially surgery, who, you know, when one of these articles comes out, our patients start asking us particularly pointed questions about what our anesthetics are going to do to their brain. So what our patients know about long-term postoperative neurocognitive disorders coming in kind of looks, I think, like this. It's heavily informed by anecdote. Often somebody knows somebody who had a really bad cognitive outcome after a major surgery. It's informed by the popular news articles, most of which use as the lead, as the sort of introductory example in the article, an anecdote about long-term durable cognitive change, and then go on to discuss peer-reviewed medical literature that might have recently come out, which may use a very different definition of postoperative cognitive change, coming to this conclusion that I, the patient, have a 15% chance potentially of permanent, functionally impactful cognitive decline, just like Uncle Frank's poker buddy, just like Dan Cole's dad. I read it in the Washington Post. And so I want to draw some distinctions between research postoperative cognitive decline. I'm using the old term here, PND in the slide title, POCD. That the terminology is messy here, in part because of the redefinition in 2018. A lot of the old stuff kind of creeps in. Research POCD, which we have a lot of information about, doing rigorous neuropsychiatric testing after surgery, and then anecdote POCD, which is really important to our patients in the way that they understand long-term cognitive outcomes. But studying long-term postoperative cognition is particularly tricky. I've put a little 3-month timeline. There's a little tiny 3-month cognitive trajectory there. Somebody has a surgery, maybe they experience delayed neurocognitive recovery or even meet definitions for postoperative neurocognitive disorder by not recovering their cognition postoperatively soon enough. But 3 months is a really small snapshot in an older adult's life. And I've drawn out some potential preceding and following cognitive trajectories that are plausible. Most research POCD is assessed relatively in the short term postoperatively. And that is just the reality of the difficulty of getting detailed neuropsychiatric tests done in a large population of experimental subjects, getting them to come back for a lot of tests. The problem is that those 2 anecdotes that I shared with you are talking about a different timeline here. This is 2 years of cognitive change that was experienced in those 2 news articles leads. So important to recognize that long-term cognition is particularly sensitive to your preoperative rate of cognitive change. And here I've drawn out somebody who's experiencing catastrophic postoperative cognitive decline. With a star there at 2 years, if you do cognitive testing and they score down there, but what they were doing preoperatively was kind of this nice green dotted trajectory, you could say that this person is suffering outsized cognitive decline after their surgery that was perhaps not anticipated. Here's what it would have looked like if they had no change in their cognitive trajectory and their cognitive outcome. But for this person who is on a worse baseline cognitive trajectory, that 2-year outcome could be very expected, could be very consistent with how their cognition was changing before surgery. And so we cannot assume that older adults all have the same preceding cognitive trajectory. There is meaningful heterogeneity among older adults' late life cognitive trajectories, irrespective of surgery. And a lot of this comes from the dementia literature. So this is a study published in The Lancet that looked at the evidence for causal impacts on cognitive change that accrue through late life. And so low education in early life, midlife hypertension, add it to smoking and social isolation in late life, we can come up with a profile of risk and a rate of anticipated cognitive decline and dementia probability for people irrespective of medical exposures like surgery. But also health changes themselves lead to cognitive changes. And this has been, again, in the epidemiological literature, this has been shown sort of starting over the last 5 to 7 years, maybe. So, okay, if one models cognition before and after a stroke using a large population-based data set, not surprisingly, brain dies, cognition gets worse. So here's a little inflection point in this late life average cognitive trajectory, where if you experience a stroke, you were declining faster than normal non-strokey peers. And at the time of your stroke, you have an acute decline and then worse decline subsequently. But also people experience a change in their cognitive trajectory after a coronary event, after an MI, for example, and after a medical admission. This is data from the English longitudinal study of aging. They modeled stroke there in the blue. They also modeled the impact, the cognitive impact of a medical admission, like for pneumonia or something, non-surgical. And it is a small but measurable decrement in cognition that occurs on average across the population. Health factors are very important to contributing to somebody's late life preoperative and postoperative cognitive outcome. So here are some kind of hammer over the head examples. They're not very elegant, but they're clever use cases for surgery and long-term cognitive outcomes, I think, because we know that 2/3 of ventricular assist device candidates have cognitive impairment compared to population norms at a relatively young age. Similarly, lung transplant candidates, nearly 50% meet impairment thresholds, and kidney transplant candidates, which is interesting because I don't think of kidney transplants, as affecting your brain oxygenation or something that's, very directly plausibly connected to cognition, but 58% of kidney transplant candidates are also impaired compared to age-matched norms. And if you do a surgery, implant the VAD, replace the lungs, give them a new kidney, these people experience cognitive improvement on average after 3 months. Sorry, I caught my kid's daycare upper respiratory virus last week and I'm still recovering from it. So on average, fixing the failed organ improves people's cognition in these situations. So in an attempt to try and control for the fact that people who have a CABG have also possibly had a heart attack just recently, have also clinically significant coronary disease, we published this study last year in JAMA that used a large population-based data set to look at the cognitive impact of having a CABG surgery, so open heart surgery, bypass, general anesthesia, high rates of delirium postoperatively. Compare that with percutaneous coronary intervention, or a way of fixing a clogged heart artery that avoids those exposures. And what we found was not only was there no difference in the cognitive trajectories on average for those who underwent PCI or CABG, but also there was no change in the rate of cognitive decline at the time of CABG or PCI. On the right side panel is dementia probability. Those were also mathematically indistinguishable between CABG and PCI. The problem is that saying that it's all the same doesn't appropriately account for the fact that something happened to Dan Cole's dad and something has happened to the people who describe anecdotal severe durable cognitive change. So we applied definitions, adapted definitions for postoperative cognitive disorders to the cohort who we studied in this JAMA paper and found that about 5% of the PCI cohort and 6% of the CABG cohort met criteria for major neurocognitive disorder or a major decline in memory performance. That was on average in that group equivalent to about an additional 25 years of cognitive aging. So if you were 65, you emerged from your surgery perhaps being 90 years old cognitively. At an individual level, these definitions are highly meaningful. Individuals can have a great result from their surgery, but they also can experience complications. And so understanding what postoperative health factors influence postoperative cognition should be considered, I think. We need to be moving from averages to individuals, and we need to be more precisely characterizing the postoperative events that happen to people who experience outsized cognitive change, like Dan Cole's dad. So if you admit there's heterogeneity in cognitive outcomes after surgery, you should be able to identify some super decliners, as we did with this paper. These may be people who were already on a rapid trajectory of decline preoperatively. We haven't excluded that using any sort of methodology here, but they also might be people who experience postoperative delirium, or unfortunately, a covert stroke is quite common after non-cardiac surgery in 7%. Contributions of things like infection or depression or pain are understudied. And if you think there may be super decliners, there may also be super improvers. People who exercise more or participate more in meaningful social activities. Who are these people who have good cognitive outcomes after surgery? Sorry. Ooh. We tried to take this JAMA cohort a step further in some pre-publication work here. and develop a prediction model to identify people who were at high risk of major postoperative meeting criteria for major POCD, which I think is more analogous to anecdotal POCD using this cohort. And just briefly, because I'm not going to share the full model, it's pre-publication, there were some really big differences among the people who got major POCD compared to the whole cohort. They were on average older, more likely to be frail, less likely to have an obese BMI, and they had a shorter period of recovery between when they had their surgery and when they were interviewed. So if we can come up with a model to predict who's at high risk of these complications, we might be able to do a better job offering resources or counseling about whether an anticipated cognitive outcome is likely to be consistent with someone's goals. So in order to do a better job managing long-term cognition, I think we first need to start reconciling the anecdote with the research definitions and thinking about functionally impactful long-term cognitive change, measuring it and understanding it better. Prediction models to use in shared decision-making will be tremendously helpful here. And we need to figure out a way to roll this out among all older surgical patients, because this is something that can happen to anyone. Thank you, everybody. I'll turn it over back to Miles.
Great. Thank you, Dr. Whitlock. Great talk. I enjoyed it and couldn't agree more with this idea of individual trajectories being important. Patients don't know if they meet a research cutoff, and nobody says, oh, great, I only have a 0.99 standard deviation drop, not a 1 standard deviation drop, so I don't have NCD postoperative. They just know if it bothers them. So excellent point. Without further ado, I'd like to introduce our last speaker, which is Dr. Stacie Deiner, who's a neurosurgical anesthesiologist with research interests that focus on ways in which we as anesthesiologists can optimize perioperative care to improve recovery in older surgical patients. She's an NIA and AFAR Beeson K23 scholar. Her project focused on identifying risk factors and outcomes associated with POCD and whether intraoperative anesthetic depth affects long-term cognitive outcomes. She's been a co-investigator on an R01 randomized controlled trial of dexmedetomidine, and one which focused on the cognitive effects of anesthesia without surgery in healthy volunteers. In 2019, she was recruited to Dartmouth to be the Leroy Garth Vice Chair for Research. And in 2020, she received a Levy Incubator grant at Dartmouth-Hitchcock to implement multidisciplinary care for older surgical patients. She's chair of the ASA Brain Health Initiative and a director for the American Board of Anesthesiology. So we're lucky to have you here today with us, Dr. Deiner. Thank you.
Thanks, Miles, for the kind intro. And thanks for the shout out, by the way, Dr. Barreto Chang. And it's a great honor to share the stage with these two women and, of course, Dr. Berger. So let's switch views. All right, so here we go. So today I'm going to talk to you a little bit about implementation of brain health type programs in your institution. You know, I think, excuse me, you can't see my screen?
Nope. I think you need to share a screen.
Let's say that. Okay, hang on a second. Let's do, yeah, that should work much better now.
Great, thank you.
Thanks for the heads up. I appreciate it. All right. So, you know, just piggyback on what Dr. Whitlock said, you know, we really need better pragmatic data about what happens to people's brains. And some of the really important information we need is how people were doing before surgery. But there hasn't been, you know, there's not an easy roadmap to get there. You know, some very important large programs, especially the American College of Surgeons, has been super persistent, really over the last decade, talking about a roadmap for better care for older surgical patients. And I feel like the American Society of Anesthesiology squarely has committed to being part of this work with the ASA Brain Health Initiative, which, you know, since we've been talking about Dan Cole a lot now, when Dan Cole was the ASA president, he actually convened a special task force to focus on brain health. And that's how we started some of the quality work that we do now as anesthesiologists. And parenthetically, I'll say that it's the first public health initiative that the ASA has ever done. So this is really new territory for us. And starting programs is really a lot about implementation science, which isn't per se part of your anesthesia residency. So while I'm going to start by talking to you about the American College of Surgeons Geriatric Surgical Verification Program, I'm going to talk about that briefly, but also talk about the beyond part, which has to do with some tips that we as anesthesiologists can do in our OR. Maybe some of them you'll even think about doing tomorrow to improve your care of older adults.
So I think you need to click on display settings. I'm sorry.
Excuse me?
You see your next slide. So if you go up to the top and click on display settings on the left side.
I just advanced one slide right now. Do you see the next slide?
Yeah, we can see 2 slides right now. So if you go to display settings.
Okay, I'll flip it again.
Perfect. Thank you.
Thank you very much. So I think that Dr. Berger covered my disclosures really nicely. The American College of Surgeons really has several quality programs. Some of them mostly collect data, and others are about multi-point programs to improve the care for older adults. So NSQIP would be an example of a data collection. The trauma program, the children's program, and the geriatric surgical verification program is actually an example of things you have to do in order to receive a certification. So the American College of Surgeons verification program has 32 standards, which were whittled down from like 300 suggestions to improve pre, intra, and post-operative care, and includes important things like talking to the patient about their goals of care, vulnerability screening, as we heard about earlier today, multidisciplinary support. And I really can't say enough about the power of working across specialties to help older adults. The program that we started at my own hospital includes a geriatric psychiatrist and a geriatrician, and they're hard to come by at a lot of hospitals, but if you have any access to these people, even if they don't have an inpatient footprint, even if they can attend weekly conferences, they really help you think about planning for your patient's recovery. And the verification program also talks about having a geriatric friendly environment, which includes the rooms that they stay in. All of us have walked into patient rooms and seen bad hygiene for sleep or fall risks. You know, sometimes these are low-hanging fruit, and other times they're very difficult to change because of space constraints. So without further ado, I'm going to do a David Letterman style top 10 things you can do to improve postoperative brain health. So number one, you can talk to patients about delirium. You know, patients who have had an episode of postoperative delirium before are fairly likely to have an episode of delirium again. And a lot of them won't necessarily tell you about it. Some of them are embarrassed. Sometimes they will tell you if they're scared and they're hoping it won't happen. But so a good intro line on that is some patients over the age of 65 are temporarily confused after surgery. Has that ever happened to you or someone you know? So just a low bar way of sort of opening the conversation. Other things that people sometimes say, which may be a surrogate of postoperative delirium, is, you know, having a patient say it took them a long time to wake up after the previous surgery. They're out of it for a long time. Maybe they had problems seeing something that wasn't there. And then, of course, you want to find out about contributing factors. So not everybody shows up to the hospital with their hearing aids and glasses. In fact, when I arrived at Dartmouth, people used to tell the patients not to bring the hearing aids and glasses because they might lose them. And so we did a special program where we now give out a bright yellow box for your hearing aids and glasses. And that's actually been one of our most popular implementation tools so far. So the number two thing you can do is gather some objective evidence about the patient's delirium risk. So when Dr. Barreto Chang mentioned the paper that we wrote surveying anesthesiologists about how often people, anesthesiologists and anesthesia providers were screening patients for preoperative cognitive impairment, which, as Dr. Whitlock mentioned, is like the major factor for how your brain recovers after surgery. We were pretty disappointed with the fact that less than a quarter were really regularly talking to patients about their brain and screening them. So one of the things that our membership asked for is recommendations that came from anesthesia providers, because before that, they were all from the American College of Surgeons about what we should be doing for older adults prior to surgery. So in the British Journal, we put together a consensus article based on a pretty simple Delphi consensus panel from a number of experts, and we recommended that all patients over 65 should receive baseline cognitive screening. We didn't say any one particular tool because we wanted to recognize that everyone's environments were different, but at the very least, you should choose a simple tool suited to your busy environment. Nowadays, the fact that some people are doing their preoperative testing not in person may influence your choice of tools. So the mini-cog is something that you do in person, but there are plenty of things that you can choose if you need to examine a patient over the phone. And I'll say, if you're looking for tools to help you screen older adults, I refer you to the ASA Brain Health Initiative website. We have a really nice tools icon. And if you click on that, we can give you some suggestions of tools you might use and how to score them and use them in your patients. So, another nice thing you can do is understand your patient's individual risk. This is the American College of Surgeons risk calculator, which you put in things about the patient's health and it predicts how they're going to do. But recently they have a very nice part that also allows you to add geriatric specific risk factors. So you can talk about their functional status, their cognitive impairment, which then allows you to report out on geriatric specific outcomes, which you can then discuss with your patients, such as postoperative delirium, the likelihood of functional decline afterwards, and things like mobility aid use. Number 3 thing you can do is talk about the patient's mental status in and outside the operating room. People forget at handoff time to talk about what an older adult was like before surgery. And if you have concerns about the patient developing delirium after surgery, that's a good thing to talk about as part of the time out. It is absolutely a safety issue. And if you're handing your case off, if you have a patient with delirium risk factors, if you have a patient who has cognitive impairment, or even if they're doing well, it's important to tell the person who takes the case over from you what they should expect when they wake that patient up later in the case. And in the PACU, you should be signing out mental status and delirium risk to the nurses, residents, and extended care providers. So in our hospital, we use something called an IPASS tool. And interestingly, I really had to lobby pretty hard for mental status / delirium risk to be part of it. You can use any tool that you want to, but having a systematic handoff and including cognitive status before surgery and your concerns about delirium is incredibly important. Number 4 thing is to have order sets for older adults. Now, who writes the orders for older surgical patients? Well, often it's the lowest person on the totem pole who may not have geriatric concerns in the front of their mind. So if you can help them by having a pre-canned and pre-chewed orders that help people not choose bad medications and then choose the appropriate dose of good medications, you'll be better off. And so this order set that I'm showing you is something that an outtake from Epic, you can tell because at the bottom there's a spelling mistake for delirium, is something that we created to help surgical residents choose appropriate pain management for older adults. And that same order set has a bunch of different drop downs and scenarios and allows you to think about creatinine clearance. And it gives prompts, things like the role of ketorolac, but also things like the use of lidocaine patches. So there was a wonderful article that came, so point number 5, familiarize yourself with opioid and non-opioid strategies for older adults. There's a wonderful article that came out in Anesthesia and Analgesia that talked about the hierarchy of what you should be doing to address pain for older adults. And I think that some of it were things we're all familiar with, but it certainly very clearly said, I like how it says always consider whether you can use local, regional, topical, NSAIDs, or non-pharmacologic therapies, which include things like icing. And then it very clearly puts gabapentinoids even under opioids. This is an algorithm from the same article. And while it may not be in our wheelhouse to use things like cold or appropriate movement or sleep hygiene, we can be aggressive partners in working with surgeons to create appropriate postoperative order sets. In looking through the literature to say something sensible about the approach to opioids for older surgical patients, I was not very impressed by the quality of the literature. You see people going through a bunch of things about pharmacology and ending up saying start low, go slow, or half dose. And so that, of course, begs some really obvious questions like, at what age do you want to think of somebody as an older adult? What do you do with opioid tolerant patients? Of course, there's the effective procedures and sometimes whether a non-narcotic option could be an option for that patient, either because of the surgery or because of their medical conditions. I think having a very close relationship with your pain specialist for opioid tolerant patients and then open communication with whoever's doing regional anesthesia is a great idea. And remember that old probably isn't a single number. You'll see vascular surgery patients who really are probably quite old, but maybe at a very young chronologic age. And then you'll see, very young looking older patients, and then patients who have challenged their bodies with all kinds of opioids. So my number 6 tip is to identify patients at risk for alcohol withdrawal. Please remember, it is not just young people who abuse alcohol. Alcohol withdrawal is a very real reason that people develop postoperative delirium, and it's very complicated to manage in older patients, especially because most of the things that you would use for withdrawal also contraindicated in older patients. If you have a heads up that your patient might be at risk of alcohol withdrawal, do think about working with geriatricians or geriatric psychiatrists to come up with a plan of how to approach that patient. Tip number 7, think about where there are the weak links in your delirium prevention path. So I would say one of the things I've learned from running a quality program is you're only as strong as your weakest link. So, you can tap any first-year resident and they'll say, well, you shouldn't be giving, and of course this is controversial, but there are many tropes about giving benzodiazepines to older patients and at what age, but at the same time, sometimes older adults will get very aggressive sedation with regional blocks. So if you have a practice, even if it's not part of your intra-op anesthetic, it's important to think, where else is this patient potentially getting GEARS criteria medication? Electronic health records, you need to be aware of how often your meds may not be updated in the electronic health record. Patients are not always forthcoming about their use of all kinds of drugs, but certainly sleep aids and anxiolytics. And so sometimes it's important to ask a pointed question about whether they take them. Anecdotally, I can say in the research studies that I've done, I want to say 40% of one of our cohorts was taking at least one GEARS list medication before they came in, and that felt like a lot. Often you won't see an updated problem list in the electronic health record. So, certainly don't count on the fact that someone will come in with their cognitive status before surgery documented unless you're the one to document it. Another tip, have a family member or a carer on standby, not a career. Can the support person remain available in the postoperative period? If you have someone who's high risk for delirium, consider figuring out how they can stay in touch with you to see how the person wakes up. It is sometimes amazing how well you can avoid having to do pharmacologic interventions if you have a caregiver on standby. And remember, video visits have actually been shown to be effective in reducing postoperative delirium. They did a really nice study at Vanderbilt, and many of us now that we're in the COVID era have seen HIPAA compliant platforms to do video visits so that patients can actually see their families. Tip number 9, it takes a village. Use yours. Keep in mind that every setting is different. I can talk about a geriatric psychiatrist, but maybe that's not somebody who's in your wheelhouse. I can tell you other parts of our team that we've leveraged include geriatric chaplains. We use geriatric alternative providers all the time. We have a healing arts team, volunteers who come in and do music and Reiki and therapeutic harping. We're associated with a college, so a lot of times we use students as volunteers. So I've heard people say they have, occupational therapists are doing their delirium screening. There's no reason to put anyone in a box. Think about who might want the opportunity to work with older adults who are in your environment. And finally, I'll say examine your practice. Carol Peden, who's been a part of the ASA Brain Health Initiative for a while now, is an implementation scientist and an anesthesiologist. And she's a big fan of documenting what you do and looking at your pre-intervention and post-intervention numbers. You can leverage your electronic health record to identify all kinds of markers of how you're doing when it comes to taking care of older adults. Beers list medications. These are a list of medications that are contraindicated in older adults. The list is updated every 2 years by the American Geriatric Society, and you can actually put together a list of those and see how often your patients are getting these in your care setting before and after, say, doing some sort of an educational initiative. You can look at how you're doing in terms of dosing your older adults. You can look at how well you're controlling the patient's blood pressure. You can look and see if you're doing enhanced recovery protocols, whether you're having to give rescue opioids in the PACU. One that's near and dear to my heart is that what is the level of consciousness of older adults coming into the PACU? If everybody is coming in with a Richmond agitation score of less than -1, perhaps these patients are being over-sedated in the OR. How close can every patient come into the PACU being ready to leave that PACU? And what is your PACU length of stay? However, of course, all of us know that sometimes PACU length of stay has to do with bed availability. In any case, many thanks to the ASA team and the Brain Health Initiative and my local support at Dartmouth-Hitchcock, and of course, always my chair. Thanks.
Great. Thank you, Dr. Deiner, and thank you, Dr. Whitlock and Barreto Chang, for your talks as well. There's been some active goings on in the Q&A. I see there's 8 questions that have already been answered, and there's several comments and questions in the open chat. The first one, for whoever wants to answer it, is there any tool that's most reliable to screen patients perioperatively?
I think reliable is an interesting question, right? I think that a good tool to start with is the one that your setting will actually do. If you'd like a menu of good tools, Kate Price and her group did a really nice review article about choices of screening tools, and that's actually posted on the ASA Brain Health website. So if you go there, we've tried to update all of our most recent articles with recommendations and evaluations of the different screening tools, so you can choose from that menu of things you might like to do at your institution.
Great. Dr. Whitlock or Dr. Barreto Chang, anything you want to add to that?
Yeah, I put in the chat a little bit, but I think the best cognitive tool is the one that is feasible to do in your institution. The one that we're using broadly among all surgical patients is actually not right now, is TABCAT. It would be great to do TABCAT among all surgical patients. We don't have the resources for that right now. We make them spell world backwards. It doesn't perform super well in delirium risk stratification, but it's better than nothing. And it's something that we're doing. So whatever you can wedge into your hospital's culture in the very busy perioperative setting is, I think, a great place to start.
Yeah, I don't have anything else to add. I mean, basically, whatever is available to you, and that's just like a good start point, basically.
Okay, great. So we have a second question here from David Honan, who describes a potential RCT that would compare propofol versus gas anesthetics with or without pressor support, so 4 different groups, and then potentially a control group, and asks about any thoughts on the rationale. I can comment briefly on it because we've done part of that. We have a study that's an RCT of, or a nested RCT of propofol versus isoflurane. We looked at cognition and we looked at CSF Alzheimer's biomarkers as well. And I can just say we found no difference between groups in either of those. I'm curious if any of the other panelists have comments on this proposed study Dr. Honan is talking about.
Well, I think the study that's about to start up, or is in the process of starting up, is the Thrive trial, which is being run by the investigative group through MPOG. And I think patients will be randomized to either total intravenous anesthesia or gas. And I think it'll be a large enough study, so they certainly will be able to make those outcomes, although that's not the primary purpose.
Yeah, I mean, the other thing I would add is that there's sort of 2 separate questions here. One is, which is better for cognition in the way that the drugs are actually used by clinicians? And then the other one would be sort of intrinsically, which drug is better for cognition? And the second question is hard to answer clinically. You could answer it in a basic science setting by doing a dose response curve of each drug. The issue is, as we all know, propofol and isoflurane are dosed so differently. It's really, really hard to come up with any idea of what equipotent doses would be. I mean, they're not even delivered in the same way. So I think that's challenging. There's a question about dexmedetomidine, and I think Elizabeth, Dr. Whitlock is typing an answer to it as we speak. And then we have time for just one more question from Dr. Orser from the University of Toronto, who asks, how do we differentiate causal factors and prevention strategies that target early deficits and longer term deficits? Curious to hear everyone's thoughts on this. I hear a stunned silence. Dr. Whitlock, any thoughts?
Yeah, so it's tough. I think causal factors often will need to be associated, done with a randomized controlled trial. Associational factors are still useful for prediction, though. You don't have to have a causal relationship. And I briefly alluded to obesity appearing protective in late adverse cognitive outcomes. So no hypothesis that obesity actually causes better long-term cognitive outcomes, but you can still use it as a predictive factor so you can identify a population at risk. As we move more towards understanding risk profiles, there will be some that are worth investigating in a causal way. And I think one will need to do that with a randomized trial methodology.
Other thoughts, Dr. Deiner or Dr. Barreto Chang? One other point I would add in response to Dr. Orser's question is it's useful to think about Sharon Inouye's model for delirium here, which is that it arises from a mixture of predisposing and precipitating factors. And we've heard talk about many of those today, predisposing factors like preclinical dementia or impaired cognition preoperatively, et cetera. And then there's the precipitating factors, the longer surgery, the huge blood loss, potentially cardiac surgery, et cetera. And those things interact in ways to produce both delirium and probably longer term deficits. And, we still have a lot of work to do to figure out how all those interactions work. But My own personal sense is that the predisposing factors are maybe more related to the long-term deficits, because something like preclinical Alzheimer's disease pathology in your brain, that suggests a certain trajectory that you're going to follow for that. Whereas, a big hit like a major surgery, often people will get delirious from that, but then will recover more so. There's a whole literature on the correlation between, early postoperative delirium and longer-term cognitive decline. But I haven't seen, and I'm curious if anybody else has seen, a study that looks at whether the delirium was more due to precipitating factors versus predisposing factors, and what impact that has on longer-term cognitive function. That's for anyone listening who's a junior investigator. I'm not going to study it. That's an excellent grant idea, I think.
That is a fascinating question.
But I think we better call it a day here in the interest of time. But thank you all for joining us today. It's been a great panel. Thank you to the three panelists for sharing the product of your brains, your thoughts with us on how to protect our patients' brains after surgery. And thank you to all of the people that participated and used your brains to pay attention to what our brains had to say. So thank you very much. Hope everybody has a good night and good afternoon on the West Coast.